All right, thanks, Dr. Noyes. Really appreciate it. I also want to thank Dr. Noyes for really being one of the early adopters for meniscus repair in this country, and really being a pioneer that's paved the way to current meniscus repair techniques. I think it's very important, and really appreciate that. I do apologize. I tend to talk a little fast, especially something I'm excited and really passionate about. In addition, I realized I have quite a few slides, so without further ado, we're going to get started here. Following my disclosures, I do think it's very, very important to save the meniscus, and I think that the fellows that work with me know that I attempt to save the meniscus at all costs, especially young patients. We do know, as Dr. Noyes had alluded to, that really the vertical mattress suture configuration is the gold standard when we look at load to failure and displacement. The various techniques we'll be covering have been mentioned. We'll go in more specific detail regarding a few of the various tear patterns. Really what we're talking about is the inside-out techniques, all inside, outside in, and a combination of all of those. So the inside-out technique really is utilizing double-arm sutures with long, flexible needles. And these are positioned with the arthroscopically directed cannulas. It does require accessory incisions to retrieve the needles, as were mentioned in the previous talk. The physicians must be careful of neurovascular structures, can be used for vast majority of meniscus tears, and it's my preferred technique for bucket handle tears. However, I sadly feel that it's slowly becoming a lost art form. As was mentioned, you're going to perform an incision medially and laterally, protect neurovascular structures. When we look at the equipment we use, really what we're looking at are usually metal cannulas of various degrees of curvature, as well as these long, flexible needles that are shuttled through the cannulas. Thanks to the work by Dr. Noyes, we do know that multiple divergent sutures are really the configuration of choice. Here's a video of a bucket handle repair that I'm placing a superior suture in a vertical mattress fashion. This is followed by placement of an inferior suture, and this creates a very biomechanically strong repair construct that's well balanced. Really, inside-out repair allows us to place multiple sutures across a tear site. It also allows us to cause very minimal iatrogenic damage to the meniscus as a result of the very small diameter of the needles, which is contrary to some of the other devices that are available these days. I'm not going to spend much time on outside-in technique. I will utilize this on occasion, not as common, just because the anterior pathology that we see is just not nearly as common as the posterior pathology. With that being said, I will typically use 18-gauge needles, use a rigid suture passing device placed through the needle, and then can shuttle a suture, usually in a mattress fashion. So the all-inside technique is really indicated for majority of posterior horn body tears. Anterior tears are less amenable. Several different products on the market today, all of them with their unique advantages and disadvantages. Although I would say that certainly within recent years, over the past 10 years, the designs have improved significantly. It allows us to be more flexible with our ability to address certain meniscus pathology. And I would argue that it allows us to actually repair more additional types of meniscus tears that traditionally were very challenging to treat. So here is, sorry, I have some delays here with this. So this is a longitudinal tear that I'm preparing for repair. This is the longitudinal tear of the medial meniscus. I'm creating a bleeding surface to enhance biological repair. This is an all-inside device. I chose to use this due to the posterior nature of this tear. And this is demonstrating placing a vertical suture limb on the inferior surface. This is after I have already placed a superior suture, so creating, again, a very balanced repair construct. Just realized that I misspelled trephination, but this is supposed to say trephination of the MCL. I will perform this technique on a lot of the medial compartment pathology that I'm dressing, and it's what I'm doing is I'm using a bevel of the needle to pie crust the MCL. Intraoperatively, what it looks like is this. It allows me to really increase that working space, allows easy access to the posterior horn to avoid iatrogenic damage to the condyle, allows me to be very thorough in my evaluation and repair. Now we'll shift focus to a few specific tear types. This is a lateral meniscal oblique radial tear. I will most commonly see these in conjunction with ACL injuries in young patients. Aaron Critch has really done a great job in describing these types of tears patterns. For today's talk will focus on the type 3 and 4. These are tears that are greater than 10 millimeters from the root insertion. Aaron teamed up with the group at Missouri and did a very eloquent robotic kinematic study and found that these two tear types resulted in increased anterior laxity for both the anterior drawer and the pivot shift compared to an isolated ACL tear. They also found increased meniscus extrusion. Here is an intraoperative video of one of these types of injuries. My probe is right there on that root fragment portion of the tear, and it's in complete discontinuity of the remainder of the meniscus. I think these injuries are oftentimes misdiagnosed or underappreciated by surgeons. This is a photo demonstrating a very robust meniscal femoral ligament, which oftentimes can cause a false sense of security of the meniscus, and so therefore the surgeon may end up resecting that root component. And really, a diagram demonstrating this is right here. This is one of Aaron Critch's diagrams from one of his papers. You see this meniscal femoral ligament, however, that does not take the place of the native meniscus fibers that insert into that root. I will usually repair these using an all-inside device. I place sutures in a mattress fashion across the tear site. I'm usually using about 3 or 4 sutures, whatever I have room for, successfully able to place. And really a diagram of what that looks like is right here. And then this is the final product of that repair construct. Shift focus to horizontal cleavage tears. Brandon Beamer did a very nice biomechanical study looking at horizontal cleavage tears. In a cadaveric model, they created these horizontal cleavage tears and then repaired them with what's referred to as a hay bale technique, which I will refer to here soon. They also assessed the contact stresses and contact areas of these specimens and compared them to resection of one of the leaflets versus resection of both leaflets. And what they found was that the horizontal tears themselves resulted in a significant decrease in contact area as well as an increase in contact pressure. The repair restored near normal contact area pressures, and this was opposed to the partial subtotal meniscectomies, which resulted in significant decrease in contact area and pressures. This is my preferred technique. I'm using an all-inside device to place a suture circumferentially around that meniscus, and this is referred to as a hay bale technique. This is followed by tie-in knots. I usually will place a sliding locking knot followed by 2 alternating half hitches. And this is the final repair, and really the goal is to close down that gap to allow healing to occur. These actually do very, very well. This is a patient of mine from my previous practice, a 16-year-old female in which I performed a combined ACL reconstruction. Unfortunately, I had to go back due to a cyclops lesion. However, at the time it was noted that she had near normal appearance of that meniscus with near complete healing. This is a very challenging radial tear to treat, as Dr. Noyes had mentioned in his talk. And this was repaired with what is referred to as a hashtag repair technique. What I did was I created vertical mattress sutures using an all-inside device, followed by horizontal mattress sutures via an inside-out technique. And then really in this technique, the red vertical mattress sutures are serving as what are referred to as ripstop stitches, which increases biomechanical stability of the repair construct. Meniscal root tear is very common in patients between the ages of 40 to 70. I always tell my patients that the meniscus has roots that go into the bone, similar to trees. They have roots that go into the ground. Most commonly in this age group, we see the posterior medial meniscus root tears, and they've been found biomechanically to be equivalent to total meniscectomy. Aaron Critch, again, has done some very nice work looking at meniscus root tears. He's documented that non-operative management of these patients does not do well. In addition, he's also documented that arthroscopic partial meniscectomy provides no benefit. So when I see a meniscus root tear, I tell my fellows that really the only reason you should be in that knee is to repair that root. Not saying that every single root is repairable. That's an entirely different topic of conversation, but I don't think there's any role for a simple debridement or partial meniscectomy in those patients. I perform a transtibial pullout repair, and a recent systematic review demonstrated that repair of these injuries results in significantly lower rates of radiographic OA and progression to conversion of total knee. And finishing up my talk here, this is the radial root tear. I use an all-inside device to place 2 sutures in what I refer to as a locking luggage tag fashion. This is a proprietary guide where I'm getting ready to drill a tunnel. This is a retrograde reamer where I'm creating a 6 millimeter by 5 millimeter socket. The sutures are shuttled through, and then the repair is anatomic and very biomechanically stable following fixation over the tibia. Lastly, I'll briefly touch upon biologic augmentation. Ora Hechala and Rob Laprade have demonstrated favorable results with marrow venting of meniscus repairs. In addition, Dave Flanagan has demonstrated that PRP may be advantageous in isolated meniscus repairs. I'm excited to be involved with a recent multi-centers trial that will be comparing isolated meniscus repair with marrow venting compared to PRP augmentation, and hopefully we'll be enrolling patients this year. So thank you very much. Appreciate it.